office. Usually demonstrations are done in hotel rooms, in artificial environments, and so our idea is that it's best to show how to do something in the actual environment where it should be done. So that is the point of our live stream today. And I have a patient, let's just call him John today, and he has a tooth that was retreated, and it was initially treated in 1995, a lower first left molar, and it failed in 2000, and it was retreated again, and then it failed again, and so I'm the third dentist to attempt to retreat this tooth. And so we're going to do it in 2 steps with calcium hydroxide, and today is the first step with calcium hydroxide. So we're going to start off with our findings. We just took a couple of radiographs. Unfortunately, we're not set up to show the radiograph that we have. We don't have that available on the computers we're viewing. But it's a lower first molar with a larger lesion on the mesial root and a small recurrent PDL space widening on the distal root. And we're going to do the testing right now. So we'll start off doing the general exam. Any swollen areas here, John, at all? Nope. Open real wide. Any tenderness down around the salivary glands? Nothing. And close down. Any tenderness in the buccinator muscles?
No.
Masseters?
No.
Nope. Open real wide. How about the right pterygoids? Nothing? Slight. Okay, slight pterygoids, Arnie. Close down. Open real wide. Any tenderness in the left pterygoids?
No.
Okay. Open and close, wide as you can, super wide. No, you don't really have any clicking, do you?
No.
No, you got a smooth jaw. No TMJ. Okay, now we'll check the maximal opening. The tri-measure opens. Oh, he's got great opening. It's definitely over 45. He'll be easy to work on. So, next thing we're going to do is we'll fill out the diagnostic information. I'll fill out that information for it. So we're going to. So as far as the radiographic findings go, in viewing, let's put both. This will be the preoperative 1 radiograph. Place that one, and then down. Then also acquire the second image also. Okay. So pre-op 2. Excellent. Okay, and so we'll go back to our diagnosis page. He's got a previous rep. So let's put this on the side. It's a clinical exam. So as far as the restorations go, he's got, doesn't have caries, has a restoration. It's been previously treated. We don't really suspect a crown fracture. There's no PDL space widening on the side. The anatomy, suspect anomalous anatomy mainly because it's blocked and there may be some curvatures that were blocked apically. Tooth is not rotated or tipped. Curvatures I would classify as gentle. Vital structure in the proximity. The mandibular nerve is in close proximity to those roots, just about 2-3 millimeters away from the CT that we looked at. And there's PDL space widening on the mesial root, on the distal root. The lamina dura is diffuse, and the distal root has, let's call it the mesial root, looks like about 3 millimeters in greatest diameter of the lesion. No furcation breakdown, no periodontal disease, no real bone loss, excellent periodontal health. And it's been previous RCT. Looks like there might be canal obstruction based upon the fact that 2 previous dentists couldn't get through get patency. I would say that's, I'm guessing it's going to be severely obstructed. And it's about 2 millimeters short on the distal. And it looks like lead zipped on the mesial. So, how long was that crown done there, John? Is that one redone in 2000? Or
Probably 2000.
Okay. Got a nice gold crown, cemented 17 years ago, over 10 years ago. Okay, looks like it has nice margins, very nice margins. And no history of bleaching, and we have all our information here. And, okay, so now, Arnie, you can go ahead and do the rest of the test. Let's take this out here. Okay, so the next thing we're going to measure is palpation. Got a little exostoses there, huh?
No.
Is that just hyperreactive bone?
No.
Bump right there.
Proplast implant.
Really? That's graft?
Uh-huh.
Interesting.
That's what I told you to look up on the CBCT slice.
Now, why did they put a...
Long story.
Well, interesting. That is very interesting.
Previous orthognathic.
Okay. So previous orthognathic surgery, huh? So previous orthodontist. Interesting. So you can switch to the microscope view, Riley. Yeah, there's definitely a bulge right there, and that is previous graft material. You can make a note that was proplast, P-R-O-P-L-A-S-T, grafting material on the buccal of number 19, related to orthognathic surgery, O-R-T-H-O-G-N-A-T-H-I-C, surgery. Excuse me. Okay. That may be open. Let's do the mobility on, and tilt your back just a little bit there. Lift your head up just a little bit there, John. Okay, mobility on number 18. 0. 19 isn't budging either. Looks pretty solid. 19 and 20. So they're all 0. Let's go with periodontal findings for number 19 right away. 3 mid-mesial, 2 MB, 2 mid-buccal, 2 DB, 3 mid-distal, 2 ML, 2 mid-lingual, 2 DL. No bleeding at all. Very healthy. I wonder if the lack of circulation in that area has anything to do with your inability to heal. I hate grafting. Okay. Let's do some ice just on the adjacent teeth, just to rule out that there's any contributory causes of the adjacent teeth. Okay, I'm not interested in how the ice feels on the gum tissue. Do you feel cold sensitivity in the tooth on this one? Yes?
Yes.
How about this one?
No.
This one?
Uh-huh.
Ooh, sharp transient. Right?
Gone.
Okay, sharp transient for 18, normal limits 20, no response, number 19, which is expected. Okay. And no palpation sensitivity here?
No.
How about on this side? No? Try something. So, any tenderness when I press those areas? No? No?
No.
Okay. Okay, let's try a percussion test. Any tenderness when I tap on this tooth?
No.
This tooth?
Slight.
Okay. Single plus for number 19. How about this one?
No.
I do 3 pressure tests. So we do percussion, bite stick, and chewing. So have you bite down there? Any problem on that tooth?
No.
Nothing? Okay, do you have any response on this one biting down?
No.
Bite down here? No?
No.
Bite down on this tooth? No.
No.
Now, let's do the chewing test. I'm going to have you chew into this Q-tip. Any problem there?
No.
Chew here.
Tiny.
Slight.
Tiny. Yeah.
Single plus. 19. How about this one?
No.
So it's not uncommon to get different tests. When you do the 3 pressure tests, you may get chewing sensitivity, you may not get biting sensitivity, may have only percussion sensitivity, but you can have any combination. So it's a good thing to test pressure 3 ways on the tooth. Okay, so I think we can pretty much isolate the problem, the tooth number 19. Our patient here has already been pretty well informed what's going on, doing his own diagnosis since he's an endodontist. And so I think we're about ready to go. Any questions before
Nope.
we get started? Okay. So our diagnosis is previous RCT with a chronic, with a periradicular periodontitis with symptoms, AAP. You can put on there. Okay, so we'll go ahead and get, now, there was a mention of episensitivity. Do you want me to do a slow injection with the 1 to 100?
Just avoid a vessel.
Okay. This is the situation of somebody knowing too much. No aspiration. I think we're out of the vessels. You get one more. Let me know if your heart's racing. Is your heart racing? No, starting? Not yet?
When I sat down here.
Yeah. Yeah, we're going to give you a little bit more. Always give 2. Felt that, huh? A little long buckle. Okay. So for vital tooth, I would wait 20 minutes. I usually go out and get a cup of coffee while I wait for anesthesia on a vital tooth. But since this is a previously treated tooth, we can get started in about 5 minutes.
I don't want that.
Okay.
So
You
we'll-
want to stay open there. Open, so do not close on it.
You don't want the suck back, do you? You don't want Legionnaire's disease, do you?
I'm fine. I give you guys a pass on everything. Yeah, I like a bite.
So we're just gonna, yeah, you can do the gross view, and we'll wait about 5 minutes, and then we're gonna get started with the molar.
You could start at any time.
Yeah, we'll give you 5 minutes. And you want some of the soft tissues a little
Doesn't matter.
Numb around there? You don't care?
I've had
Okay.
fillings without.
Okay. Then we'll do that when we get started.
Look at the graph on the CBCT.
Yeah. It's very weakly radiopaque.
Proplast is the
Yeah.
worst you could use.
Yeah. I was wondering what that was. Yeah. You know, knowing that it was grafted, I wouldn't know why anybody would graft that, you know. So it was hard to understand.
Look at the mental nerves.
Yeah.
Did you see them?
Yeah, they're yeah, it's crazy. You don't have any bone there, hardly at all.
You see the mental?
Yeah, it's in, where it comes right in.
They shoved graft in the mental.
Really, I didn't follow that. I didn't follow the 3D on the mental nerve. Interesting. I'll have to check that out.
Anesthesia for like 12 years.
Wow. Yeah, orthodontic surgery isn't a real benign procedure. Okay, so I think we're ready to get started. I don't need another one. Again, they asked me if I need an extra carton. I don't. Opener wire. Okay, perfect. So we're going to isolate the tooth. Oh, yeah, you don't want me to do that yet.
Lingual tissue, that's all.
Yeah, we'll give you a little lingual. So what I usually wait for is lingual anesthesia. We don't have it yet. I'm going to give you a little bit. I may rotate your head there. Okay, great. Wait just a little bit. Wait. Okay, let's try it again. Is that okay?
Mm-hmm.
Floss. going. And then I'm going to readjust the clamp. Readjust the clamp for a little better seal. Okay, is that okay? And place in a bite block. You okay with that? There we go. Okay, start with the 330 burr. See how soft that gold is? And usually start the penetration behind the mesial buccal cuff. This crown form has quite a buccal roll, so we'll be going over the MD cuffs a little bit. Okay. Is standard 557. They put a Fuji ionomer in there. Any questions, really? Anybody watching?
We got 28 people.
So I can see the dentin starting to peel away as I peel away the Fuji 9, or Fuji, that's the Fuji, old Fuji glass ionomer, which had the precipitated silver, I think, in it. Make it look like amalgam, huh? Yeah, we're starting to peel away towards the dentin walls. I don't remove any dentin, I just remove the filling material. And I'm pretty liberal about extending where the restoration is, because it's just restoration. I'm not removing tooth structure, I'm just removing crown. So we can see moving a lot of Fuji. John, do you know what type of sealer they use for that? You know what kind of sealer they use for the gutta-percha film? Age 26?
Uh-huh.
Okay. I asked that question because as nice as age 26 is and how many endodontists like it, it is a resin, and when you retreat it gunks up accessory canals. So we might have, might be a little bit harder to remove than a zinc oxide eugenol based sealer. So I'm just continuing to, now I'm starting to peel away. I can see the gutta-percha and the distal canal right there. I always go for the low-hanging fruit first. Distal canal is easiest to get to. That'll give me my bearings so I can peel away the rest of the material here. Okay. Let's get a little lower magnification. You know, Arnie, let's get a CP4 ultrasonic, and I'll just pick away the rest there. Visibility towards the mesial half's a little bit more complicated, so we'll use ultrasonics to remove the rest of the core on that side. And that means minimal dentin removal. We're just peeling away artificial material, leaving most of the dentin intact. He's had this done 2 times, so I'm sure he has a pretty adequate access, actually. We don't need to make it too much bigger, do we? 14. Okay, he's turned all the way up, yeah. Okay, hypochlorite, sodium hypochlorite. Hypochlorite. One thing I noticed on the CT is the ML and MB canals are very widely separated. There's got to be some connecting fin or middle mesial canal in there, I would think. Hypochlorite. Adjust the position a little bit. Okay. And let's use a safe-ended burr to get our direct. So a pulp shaper burr they use just to get our direct line access. And I think it's very important to remove all the material from the pulp chamber floor. There's a very high frequency of percation accessory canals. It's been reported to be up to 30% in incidence. Okay, and let's go with the Zerkner. Okay, and the CT4 again. Section. Okay, let's go with the 2 gauge. Alcohol first. Just dry the pulp chamber. Okay, and Arnie, just go ahead and get in their suction as I blast dry. Okay. 2 gates. Just kind of let the heat just melt the gutta-percha and have it come out without not really moving any dent and not really removing the widening the canal at all. Letting the speed and heat of the burr just remove the gutta-percha. If the pulp chamber is wet, this doesn't work as well. Okay, 3 gates. Okay,
4.
and 4. Don't worry, I don't go very deep with that. It scares you. That's just with the orifice. Okay. Yeah, it's funny. People have misconceptions about gates. You use them passively and you don't let them really, you don't push them into dentin. They're not a problem at all. It's a great burr. But they've been maligned because everybody sells more expensive ones. And gate squid and burrs are cheap, so everybody's got a more expensive burr to sell you. Okay, let's go with C solution. Okay, so we've just I usually like to start off the 15 file. Has enough stiffness to work the gutta-percha, and it's small enough to get down to the terminus. I'm just gradually working it, letting the gutta-percha melt as I push into it. So we're working on the DL right now. Figure out if that's the blocked one. And I have my assistant pre-curve the files so I can go very efficiently and go through a whole file series. So I want to keep the pulp chamber flooded with the chloroform so it doesn't start gumming up. Keeps it in loose suspension. Solubilizes the gutta-percha and it can be removed. We have a Mani. Put one of those Mani files in there.
You use both of them.
Got one, or the other one. The other file, Sono file's fine too.
There's actually one here.
Okay, good. Okay.
Want to use that one?
Yeah, Mani file will be great. Okay, more C solution. I use more chloroform. I use as much chloroform to put an elephant to sleep when I remove gutta-percha. Okay. Ultrasonic file. You okay, John? You feeling that at all? You're feeling it? That's interesting.
Hot heat.
Feeling that?
Yeah, yeah.
With the ultrasonics, you were.
Heat.
The heat. Wasn't much heat on that. I missed the black. Feels like I got patency on that one, ML. Still some gutta-percha. Okay, C solution. I'd like to see it come out clear. Let's go to greater taper file, 0.06. Not feeling that, huh?
No.
Did feel the ultrasonic. What setting was that on? That was 4, right? Or we had a 5?
6 for the morning call.
6, yeah. Okay. So we're working just on the DL right now. I do one canal at a time because you want to really clear it. Okay, C solution. Okay, go through another set of recapitulation. 10 file, 15. Passively, I'm not really pushing them that much. I'm just letting it go where it goes. Okay. Okay, I think we removed most of the gutta-percha to the ledge point on that, so we'll stop there. C solution, move on to the DB. We'll turn the Monty file down to 4. For some reason the 6 level wasn't too comfortable for him. Okay, C solution again. Clear. Okay, down to 4. See how that does for him. You okay?
Mm-hmm.
Okay, let's try 5. Felt that, huh? Let's go alcohol. Okay, here's our first preview. The patency on that. Okay. Hypochlorite again. Okay. Hypochlorite. Okay, so you can see there's a 2-canal DV system connected by a fin. Let's go with C solution, more C solution there. Okay. S1, let's go with the rotaries. S1, S2, okay, hypochlorite. Angle that towards. You feel that, John?
Right.
You only feel the ultrasonic, huh?
Right.
You feeling that a little bit?
Earlier. Okay.
Rotary files shape, but they don't clean. Recapitulations with a pre-curved hand file. Just needs a little slight curve on the larger ones. So that's pretty typical for like a 30 file. Not much of a curve on that one. Very slight, gentle apical bend. Okay, and about alcohol again. I'm going to have you rotate your head just like that, John. Okay, microsuction tip. I'm getting it clear. Pretty good. You can see how we're just gradually removing all the gutta-percha between the fin and the two canals. So let's go more C solution. Use the ultrasonic right between the fin, right in the fin area. Oh boy, that's amazing, huh? You don't feel the files, but you feel the ultrasonic the minute that's on. You don't feel that, huh?
No.
It's very bizarre. Must be your specific radio frequency. Okay, C solution. Again. Okay, let's go with alcohol again. Try it. See if we're clear. Okay, so the focus right now is just to remove all the gutta-percha from the distal system. Microsuction tip, and it looks pretty clean. Yep, that looks pretty clean all the way through. So we have all the gutta-percha removed from the distal system. Maybe I need to speak up, I don't know. Okay, let's go C solution. We'll do the mesials now. Very interesting sensitivity with just the ultrasonics. Huh? Hate and see with the regular files didn't bother you, huh? Maybe just a little bit, but the ultrasonic was intense.
Mm-hmm.
gradually working the gutta-percha out with the small files. C solution. You can show the gross view if you want. C solution. Using a greater taper file, just a little stiffer. Really don't like using rotaries to remove gutta-percha, simply because I don't like the risk of potential separation. So I may use the rotaries towards the end, but early on I use pretty much all hand files. Safer and cleans better. If all you use are straight rotaries to remove gutta-percha, you're just going to leave gutta-percha smeared along the sides, and you're not going to remove all the previous filling material. Not thrilled they use our age 26. C solution. Okay, now they're going to use a S1 safely there. Okay. That's it. C solution. Okay, John, I'm going to try the ultrasonic on the ML canal, see if that one bothers you. Does that bother you? Not too bad? Boy, you and ultrasonic energy don't get along, huh? That one's not too bad on that side. It's a distal. It was intense. By using the ultrasonic, though, file with the sure zips the previous filling material out quickly. Yeah, right down to the block point right there, I think. Okay. You get there. One block it.
There you go. That's all right.
You feel it?
Oh, that's all right.
Bathroom break?
Uh-huh.
Okay. Okay, we'll let you take a break right here. Bathroom break. I'm not going to the bathroom because I'd be mic'd up while I was going to the bathroom. I don't want to do that. Got to turn my mic off if I use the restroom, huh? That's what you'd call a live stream.
Do you want me to pause it or just keep it running?
I can keep it running.
Turn your mic on.
Okay.
40.
Yeah.
Somebody asked, is he feeling the heat from the ultrasonic? Make sure your mic's on.
Yeah, I'm not, you know, quite frankly, I'm not sure why he's sensitive to the ultrasonic. That, not so much of the filing, but the ultrasonic. I don't know if it's the heat. It really wasn't in there long enough to be heat, because the minute I placed it in there, he got a reaction. Probably the frequency, probably stimulating. It's just kind of an anomalous reaction that I can't really explain. I don't know why you're feeling the ultrasonic. Higher frequency, more intense stimulus, maybe.
Mesial from distal was very strong.
Distal is very intense. So that kind of limits my ability to clear the debris, but, you know, we can, we'll get there. Okay, we're back.
acoustic screening against the PDL.
Could be.
This is Imran Kassim, by the way.
Hi, Imran. Good assessment. I was glad somebody could add some input into the ultrasonic reaction he's having. Could very well be a PDL reaction. Okay. Okay, more C solution. Okay, so there's, I'm going to do an ideal bend for the, so when I curve, down right now, okay, I'm going to show, it's bird beak pliers for orthodontics. I grab just the tip of the file and barely roll it. And the whole idea is to have a very smooth apical bend that isn't crushed. There we go. I think we have patency there. PML. C solution. Greater taper hand file 0.06. C solution. Okay, we're going to do the MB now, last one to clear. So access to the MB is a little bit constricted. I may just pull out the extension to the MB cusp more. Only thing you're conserving is not dent, you're conserving gold, not tooth structure to extend the occlusal outline. Okay, John. Powder on the gloves. C solution. Head over. C solution. And over. So a small file will pierce the gutta-percha as it's solubilizing. I think they had that. This is the one that was probably blocked, the MB, because the access was tough. I'm going to really pull out the extension. I'm going to improve the access on this one. Okay, C solution, more. S1. That's it. C solution. Okay, ultrasonic. Let's try the MB. Not too bad, huh? That was a distal, sorry. The distal is just intense. Huh? C solution. That is the distal. Okay, C solution. Then alcohol. Protect your head just like that. Okay, do we have a Versa brush? Grab that. I'm gonna just wipe this clean. It's a rotary brush just to remove all the extra gutta-percha. Okay, and alcohol. Okay. Still got some Fuji on the pulp chamber floor that we're going to remove. So we're going to get rid of the last bit of the Fuji. Okay, suction, just keep that on. Okay, suction. Okay, last spec. There it goes. Now there's quite a significant groove between the ML and MB that we're going to have to trough out. Okay, C solution. C solution. C solution. Okay. Promise I won't go into the distal, the ultrasonic. That one is tender, huh? That's the MB. Feel that? You okay?
Mm-hmm.
Okay, S1. You may have to lift your head up just a little bit. There we go. Okay. Okay, we're going to go all through the whole series. S2. Okay. F1. Okay. F2. Okay. Okay. And alcohol. More alcohol. And so we go in the mesials only here. Boy, mesials are sensitive. That must be PDL. Must be acoustic. Yeah, that's a good explanation. Acoustically affecting the fibers of the PDL that may be sensitized from the inflammation. The files aren't doing it at all. You're not feeling the files, are you?
Uh-uh.
Unusual reaction. Hypochlorite. That's patent on ML right there. Ready for the root ZX in just a second here, Arnie. Hypochlorite. rotating on the MB. Got a little light anesthesia there. Huh? Feel that a little bit? No? A little bit. Okay, hypochlorite. Okay, I think we're painting on the DL. DB is the only one I'm not sure. Yeah, we're painting on the DB. Okay, so let's get our microsection tip. Let's get our link measurements. And the last thing we're going to do is trough that ML groove. Okay, kind of left some stuff in there. Okay, so we can see. Trying to look, try and get an angle there. I'm going to make a note, since we can't take pictures because we're live streaming, we're using the camera for that. Make a note, there might be an incomplete root fracture mid-MB that nobody saw before because it was a tough angle until we flared it out. It was there before? Notice it? Yeah. So that was documented previously. Yeah, you don't have a perio defect at all, so I don't think it's significant. There's also one ML, 3 millimeters into the lingual aspect of the ML canal, extending 3 millimeters. Looks
Someone
like,
asked if that was a crack.
yes. Yes, that is a crack. We're documenting 2 cracks we see coursing 2-3 millimeters into the MB and ML canals. Interestingly, he has very normal, healthy-looking perio with no narrow defects associated with those areas. Okay. So they did document those cracks before, huh?
Oh,
One of them? Yeah, I see one on the ML and one on the MB. They probably didn't document the one on the MB because that was... You feel that? Yeah, we're just... Yeah, okay. The ML measurement. Is 20. It's a little bit long, so it's 20 from the MLCT, mesiolingual cusp tip. It's starting to ache a little bit. Okay, head over. There we go. Oh, that's it. $20 MB from the MBCT. Yeah, that's the distal. So I'm light on the anesthesia. Let me give you a little PDL. DL from the DLCT is 19 and a half. Yeah, that's that one. So, yeah. Okay. That one is 19 and a half dB from the DBCT. Okay. And you have a lip sign?
Tingle.
Just tingling?
Uh-huh.
Okay, I'm going to use a very thin tapered diamond to just now I'm going to use a cone-shaped composite finishing burr, which is not very aggressive, just to create an indentation. Okay, Arnie, I'm going to have you put the CP4 back on the ultrasonic tip. That didn't seem to bother him before. Maybe we should try a different size ultrasonic tip, see if that helps.
Okay.
Definitely some schmutz in there. You okay? Nope. Let's turn it down to 4. That's not. Five. Let's see if we can get it up. 6. Feel that. 6 level. Okay, let's use a 30 gauge and 1 to 100. I'm going to give you a little PDL, see if that helps. So, feel that, John? Do this a little bit to start. Feel that? Wes? Yeah, it's wearing off on us. Don't feel that anymore, do you? That side? Yeah. Tasting it. We're done with this. Get rid of that. Take this out. Open. Long. Open. Okay. Suction here. Open. Open. Okay. Yeah. Okay. Getting a headache? Open. Still aching? No. Let's readjust the clamp so I can get in on the lingual. One more carpet. Got to get in there with ultrasonic, so we got to get that numb. PDL is not numb. Okay. Okay, suction. Here. Okay. Open. Hate to take the dam off and get another blood. You got to get that trial. Let's see how that is. Let's see, files, hypochlorite. Still feel that. Okay. Let's see if we can drop out. Is that still bothering you or not? It's a really wild ultrasonic reaction, way high up in the canal. Hypochlorite. See if we got it. Yeah, I got a, looks like there's possibly a middle mesial right there that was missed. That's what I thought. We can just get a file in there and clean that out. Get some just initial clearance, we'll be fine. We're done. And I'm going to give you the work for the anesthetic next time.
What?
I got too light on the anesthesia. Yeah. Okay, and hypochlorite. You see the isthmus is cleared and there's a little white spot signifying a middle mesial canal. I'm going to create a little depression where that is with the Munz. Let's get a Munz spur. EDTA. Looks like it joins the ML. EDTA. See if we get a catch. Yep, we do have a catch. Let's get a short 6 file. Straight, no curve in it. Okay, we'll keep that there. Let me, I'm going to try the ultrasonic. Do this. Touch, turn it down to 4 where it didn't bother him.
Okay.
That's 4. Unbelievable, I've never seen that kind of reaction before. You don't like ultrasonics, huh? I just vibrate the tooth at all. I don't think I've ever seen that. Wouldn't you know it? On a live stream, that's what we get, huh? Okay, and so cool burr, so I can pull, like, stem the burrs out to the length I need. Okay, hypochlorite. Let's use S1. Just going to lean on an S1 instead of using the ultrasonics. Just bending, leaning the S1 against the groove and letting it run. Okay, hypochlorite. See if we got anywhere in that. Okay, hypochlorite. S2. Hypochlorite. Okay, microsuction tip. Okay, I'm going to use the burr to use a thin flame tip finishing burr to trough the mesial buccal side of that, and we're done. Again, patency in all the canals. Still fast? Okay, we're just about there. Hypochlorite. And microsuction tip. So it looked like a middle mesial, kind of looks like it comes right into the ml, and we got it. We're good. Drop that down. EDTA again. Just want to make sure we're not seeing any significant gaps in that isthmus. Okay, I think that's as much as we want to go. In fact, you have the lesion, which is the largest on the mesial root. I want to make sure we really clean nothing I can get into there. Okay, hypochlorite again. We're ready for the calcium hydroxide, which I mix a little Cleocin with. Microsuction tip. You can see there's no specks of gutta-percha down there anywhere. It's clear, patent, dropped, and fully aggravated. Lintelo.
What was that?
That was a calcium hydroxide I just injected in there. You felt that. I'm going to give you my regular injection sequence next time. You're like one of those patients who says, I'm allergic to epinephrine, huh? Oop. Sorry. Just when you gradually get it down with the,
That's Callan.
you're feeling it, John.
Callan.
I'm going to give you my full anesthetic routine next time. Okay, and
Sorry about that.
no, you're doing great, John. Sorry about that. It's embarrassing not getting anesthesia.
Oh. Okay, so
I'm going to try and push the. I use Cabot without a spacer. And use it to plunge the calcium hydroxide in. But I don't think I want to do that with you too much here. You okay?
Craig is asking which calcium hydroxide is that?
I used what do we use? The Aseptico pulp dent in the syringe, and then we mix it with the USP from the pharmacy to get it kind of a thicker consistency. That'll express. It's just thick enough so it'll just barely express through the Centrex syringe. And then I mix it a little Cleocin with it. For some reason, it seems to help with flare-ups. And don't ask me for the literature evidence on that, because I don't have any. It's purely empirical. think you're gonna want the Advil Tylenol combo, right? That tooth was pretty sensitized. You were waiting a while to come down here to have this done. And we are done. So everybody got to see me torture poor John with the ultrasonics. Very, got pretty sensitive with that. It's interesting. It was very high up in the canal too. Couldn't even trough the grooves with that. But we got it pretty well clear. I didn't take any photos because we have the live stream camera, but we could go through it and you can see the video on that. So, we are done. The live screen. Any other questions that anybody had?
Just Craig's. He asked
Okay.
if it was the USP powder plus calcium hydroxide.
Yeah, for the pulp dent plus USP. And this will be posted on the YouTube page so anybody who wants to see this procedure can see it. Okay. Thanks, Riley. Thank you, John.
Thank you.
Thank you, Arnie.
Thank you.